All right, this is our last chapter in EKG 2, chapter 17. And in this chapter, we're going to talk about the different procedures that we can do in EKG. And also, we're going to continue talking about what our EKG interpretations can look like and what they can mean. Okay, so to diagnose electrocardiography involves an EKG done to rule out disease. It can involve a resting EKG. This is one where the patient is laying down. A signaled averaged EKG. A stress test, that is the one that usually you hear about patients going on a treadmill. And ambulatory monitoring, meaning they can take that EKG equipment with them and be mobile with it. So, the signal average EKG, this takes up to 20 minutes. The machine collects about 250 consecutive QRSs. It then analyzes them, called signal averaging. Artifacts and noise cleaned. True cardiac signals are strengthened. SAEKG recording yields a single averaged, very large QRS complex. So your key points here is your signal averaging. You notice they've mentioned it twice. And also your 250 consecutive QRSs. Consecutive means they're coming right after another. And it combines all of those QRSs into one, and you get a very large QRS complex. This is called your signal averaged EKG. So when you think average, we're taking the signal of how many QRSs? 250. How long does this take? About 20 minutes. Here goes an example. So it's kind of cool if you think about it. You're looking at 250 QRSs right here, all combined into one, and you get a very large complex. Remember, it takes 20 minutes for this procedure, and this is called your signal averaged EKG. It is abbreviated SAEKG. So on these averaged EKGs, we can have what's called a late potential. It is the end of a QRS variation arising from damaged or scarred myocardial tissue. It predicts the risk of potentially dangerous ventricular arrhythmias. Remember, arrhythmia is abnormal, and ventricular means what chambers am I looking at? Where is that rhythm coming from? In this case, I am coming from the ventricles. And if I'm coming from the ventricles, my heart rate is going to be how many beats? Remember, we had your SA node, your AV node, and your ventricles. So this is a dangerous rhythm. Why? Because my atrium, are they depolarizing? No. So when we have a end of the QRS variation arising from damaged or scar myocardial tissue, this is called a late potential. It predicts the risk of potentially dangerous ventricular arrhythmias. All right, the next type of test that we can do is called your stress testing. This is a diagnostic procedure to determine the likelihood of coronary artery disease. There's your abbreviation again. Whenever you see CAD, they're not going to spell it out for you on the question. They're going to ask you, do you see any signs of CAD in this rhythm? Coronary artery disease. The goal of a stress test. This is very important, and this is a lot of your quiz and homework questions. The goal of your stress test is to increase the heart's rate with physical exertion, thus stressing the heart by increasing oxygen demand. Think about it. When you go for a jog, if you ever go for a jog, if you've ever had a run after your 2-year-old, in general, if you had to run to catch something from falling on the ground, you're out of breath, right? You're stressed out. You're stressing your body, and you're increasing your oxygen demand. This is the goal of a stress test. The patient's symptoms and EKG give vital information regarding patency, which is openness, make sure you know that, of your coronary arteries. Remember, what are your coronary arteries? We have the circumflex, your anterior, your descending. Remember, they feed the heart. So do we want our coronary arteries to be occluded, meaning blocked? No, we want them to be open. And we can tell if they are open by doing a stress test. And again, a stress test is to help diagnose the likelihood of CAD. You are increasing the heart rate with a physical excursion. You are stressing the heart and increasing demand. So this is what a stress test looks like. In this case, we are using a treadmill. Look at all those wires are attached, and you notice the leads are on his back as well. So in class, we talked about your limb leans and your chest leans, your precordial leans. When we do different types of procedures, they're going to have different lead variations. All right. So stress testing is indications for stress testing include suspicious symptoms, post-CABG or what's called post-angioplasty evaluation, diagnosis or treatment of exercise-induced arrhythmias. Again, arrhythmia means abnormal rhythm. Follow-up to cardiac rehab and family history of heart disease. What are some contraindications? In other words, when should we be concerned about doing a stress test? Do we want to do a stress test on anybody? No. So when we test these people, they could have a serious or fatal consequence. So if they have an acute MI, we talked about that in chapter 14, meaning they've just had a heart attack 48 hours ago. Do we really want to put them on a treadmill and put even more stress on their heart? No. So this would be an absolute contraindication, meaning we do not want to perform a stress test on somebody like this. What if we have uncontrolled symptomatic heart failure, meaning they are showing signs of heart failure and it's uncontrollable, it's symptomatic, they're having symptoms? Do we want to put them on a treadmill? No. What if they are having unstable angina? Now we know that is chest pain, right? Not previously stabilized on medications. So if you know, anytime you are on medications, and if you're normally not on medications, and let's say you're sick, and you start taking medication, do you feel at your best health? So do we want to put somebody on a treadmill if they're already having medication for other possible symptoms? No. Also, uncontrolled arrhythmias accompanied by signs of decreased cardiac output. So we definitely do not want to put any of these patients on a treadmill or a stress test because it is an absolute contraindication. Testing these people could have serious or fatal consequences. Symptomatic severe aortic stenosis is also an absolute contraindication. Dissecting aneurysm, acute pulmonary embolus, that's your lungs, and acute myocarditis or pericarditis. Remember your pericardium? This is that thin outer layer of a boiled egg. So if we have myocarditis, inflammation of these, we do not want to put that patient onto a treadmill or to do a stress test. So what if we have relative contraindication, meaning they're not absolute contraindication, meaning they cannot become fatal, but they are threatening. They're relative contraindications. So some individuals should have a stress test only if the benefits outweigh the risk. This is a quiz question. It's a homework question. When should you have a stress test? Only if the benefits outweigh the risk. So absolute contraindications. Does the benefit outweigh the risk? They just had a heart attack. Do I want to put them on a stress test to see if they're going to have another one? Or is that going to be a risk? It's more than likely going to be a risk. So relative contraindication is when the benefits outweigh the risk. So, for example, if my patient has a left main coronary artery stenosis, the benefit would outweigh the risk. What if it's mental, physical issues making the patient unable to exercise adequately? What about uncontrolled tachyarrhythmias or bradyarrhythmias? So remember back in the beginning in EKG 1, we talked about you have your sinus rhythms, right? And you have a sinus tachy and a sinus brady. So remember, these weren't considered arrhythmias then. So in this case, the benefit would outweigh their risk. And we know, you just learned in chapter 16 as well in chapter 14 about the different medications that increase and decrease the heart. So let's say we have a patient that goes into a tachyarrhythmia or a bradyarrhythmia. Can we treat them quickly to get them back to where they need to be? Yes. So the benefit would outweigh the risk. Severe hypertension, your systolic and diastolic, and the second and third degree AV blocks. All of these, the benefits will outweigh the risk. Again, these are test questions. These are quiz questions and homework questions. Other benefits that outweigh the risk is electrolyte abnormalities, moderate stenotic heart valve disease, or hypertrophic cardiomyopathy, or other forms of outflow obstruction. So, how do we prepare for a stress test? We need a 12-lead EKG machine is the most important piece of equipment. Electrode patches may be taped to the skin. So think about it. Your patient, had we done this in class, you would have seen how easily these leads, these electrodes can fall off. So imagine having somebody moving with the electrode on them falling off. We can tape it to their skin. Females are encouraged to wear a bra and no large meals for at least 4 hours prior to the test. Meaning you don't want your patient to have a steak and then have to come and get on the treadmill after eating such a large meal. So you want them to be semi-fasting, meaning they can have their morning breakfast as long as it's not heavy and it won't interfere with them getting on a treadmill. You want to wear comfortable clothes and loose clothes and comfortable walking shoes. You want to take meds as ordered. So you're still going to take whatever medication you are on. Only certain medications will be held, and the physician who is ordering the stress test will tell you which medications to hold. So how do we do a stress test? Prior to the test, we're going to do a resting EKG. So we're going to have our patient relax and be still, and we're going to get their heart rate, their heart rhythm. Then we're going to look at their history and description of symptoms. So this is important to know because this is your test question. If you have a healthy individual and they want to have a stress test, can they go get a stress test? No. You can only get a stress test if you have a history and description of symptoms. Baseline vital signs have to be taken before doing your EKG, stress test, and hyperventilating EKG will be done. So the exercise test. You're going to exercise while the EKG continues to record the patient's rhythm. Their blood pressure and symptoms are going to be checked at intervals. Remember, intervals back in EKG 1 is time intervals, right? So at certain times throughout the procedure of them exercising on the treadmill, we're going to take their vitals. We're going to continue until 85% of the target heart rate is reached. This is very important. How much of the patient's heart rate, what percentage has to be reached? 85%. The target heart rate is 220 minus the patient's age. Very important. Again, What percentage of the heart rate doing the stress test do we want to reach? 85%. That is our target. That's what we want to get to. So once we get to that 85%, then we can slow the treadmill down because we've reached our target. How do I know that patient's target? You're going to subtract 220 from their age. Submaximal test following an MI is going to be a 70% target rate. So if we had a patient who had an MI, and let's say they had a procedure done, and we want to stress the heart to make sure that everything is working fine before we release them from the hospital, only 70% of that target needs to be met. So radioisotopes such as thallium-201, this is again as a homework question, a quiz question, thallium-201 or 201 can be injected during the last minute of exercise to study myocardial perfusion. Very important. Radioisotopes such as thallium-201 can be injected during the last minute of exercise to study myocardial perfusion. Multiple gated acquisitions, MUGA, again, another quiz and test question. Scans can be done after the exercise test. So when do you inject thallium? 1 minute, the last minute of exercise. What is MUGA? That is a multiple gated acquisition scan that can be done after the exercise test. Another form of stress test that you can do is called pharmacologic stress test. It's exactly what it sounds like. Does it involve exercise? Nope. What does it involve? If you had me in KG1, you know it involves what? Drugs, medication. So it's appropriate for individuals that have a physical limitation that preclude exercise. So maybe I have a patient who's having symptoms of heart failure, of CAD, and both their legs are amputated. Well, how are we going to do a stress test? We can give them a pharmacologic test. The patient is giving an intravenous medication, in other words, an IV, that causes the heart rate to climb, in other words, to increase. Common medications include, but you should know this from Chapter 16. So butamine, don't know how to say the next one, but I'll try. Britamol, adenosine, and raganacine. Okay. So, what are my protocols when I have a patient doing a treadmill test, a stress test? The speed and the incline of the treadmill, as well as the frequency of changes in protocol stages, are determined by the protocol. The intensity of exercise is measured in what's called metabolic equivalents, METs. This is something else you need to know. So far we've talked about thallium. That's important to know, can be injected at the last minute, and MUGA is important, and also the target heart rate, which is 85%, and then 70% post-MI. And how do we figure out a patient's heart rate? We subtract their age from 220. So a lot of information just in these 18 slides. So now we're going to talk about what's called METs, and this is what falls under our protocol. What is the speed of the treadmill? What is the incline of the treadmill? And what is the frequency of change? So I don't want to start somebody walking, let's say at 2, and then within 1 minute times have them running at 6, right? That's not protocol. We need to find out what the exercise protocols are, and we can do this with METs, metabolic equivalents. So we have different forms of exercise protocols. The first one we're going to talk about is Bruce. It is the most common. It is used for maximal testing. The treadmill speed and incline is increased every 3 minutes to a total of 21 minutes. Again, Bruce is the most common, the maximal test. The treadmill speed and incline is increased every 3 minutes up to 21 minutes. And again, what is our goal? To reach our target, whether it's the 85% or the 70%. And how do we figure out our target heart rate? By subtracting the patient's age from 220. So, for example, of a Bruce protocol, stage 1, we might start off at 1.7. This is like a slow walk. And their incline might be at 10 degrees. Well, how long do we wait until the frequency changes? 3 minutes, right? So then in 3 minutes, we're going to change the speed. We're going to increase it to 2.5, and we're going to incline it to 12 degrees. Well, now we're having a brisk walk going on. Stage 3, the next 3 minutes, we're going to get up to 3.4 at 14 degrees. We are doing a fast walk. Stage 4 is after 3 minutes, we increase it to 4.2 miles per hour and at 16 degree elevation. We're pretty much skipping at this point. And then at stage 5, we're running 5 miles per hour, 18 degree incline, and 6 and 7. So again, for Bruce's protocol, it is the most common. It's the maximal. The frequency changes every 3 minutes for a total of 21 minutes. The next protocol we have is called your modified Bruce. Its initial work is less strenuous. The stage change is in smaller increments. So let's say maybe I have an older patient, maybe somebody in their late 60s, early 70s. I might not want to give them the most common Bruce maximum test, right? I might want to slow it down just a little bit for them. This would be your modified Bruce. An initial work less strenuous. The stage change is smaller. And then you have what's called your Norton, which is slow. Okay, so if you think you can be like maximum, medium, and minimum, right? Or slow, medium, and fast, right? So fast is Bruce, medium intensity is modified Bruce, slow is Norton. The settings change for Norton every 2 minutes. It is used most often for testing in a post-MI patient. Now remember, if I have a post-MI patient, what is my target heart rate? 70%. And how do I figure out my patient's heart rate target? By subtracting their age from 220. All right. So now we know what stress testing, why we do it, how it's done. Now we want to know, when do we stop it? When do we terminate the test? So here are the reasons why you would stop a test. If we see ST elevation, so remember in chapter 13 and 14, and I believe it was in chapter 14 we discussed ST elevation. What is that a sign of? A heart attack. Remember your 3 I's: ischemic, injury, and infarction, right? So if we're seeing any form of an ST elevation, we are to immediately terminate the stress test. In other words, stop the test. If we have a sustained VTAC, V tachycardia, if our patient is having moderate to severe chest pain, especially if it is accompanied by ST depression or elevation, if there's a drop in blood pressure, so I want you to think about it. If you're on a treadmill, what should be increasing? Your heart rate, right, which is your blood pressure. So if my patient's blood pressure is dropping, we want to stop immediately, along with evidence of ischemia, such as chest pain or ST segment depression or elevation. And if we are having any technical problems with the treadmill or monitoring system. So I want you to remember, when a patient is getting an EKG done, whether it's a stress test or a resting test or ambulatory test, we are recording the electrical signals of their heart, right? So if my patient's on a treadmill and they're sweating, could they possibly get electrocuted? Could this be a technical problem or a monitoring system? Yes. So we would want to stop immediately. So the termination of the test. If your patient requests to stop, if the patient becomes dizzy, begins to stumble, or feels faint, and if the patient becomes diaphoretic. How do we prepare for a stress test? we're going to follow EKG changes are normal. So we're going to see shortened PR intervals. This is a quiz question. It's going to ask you what is normal and what is not. So if we see ST elevation or depression, we want to stop the test. But if we see a shortened PR interval, do we want to stop the test? No, these are normal changes that we will see because we're putting stress on the heart. Tall P waves are normal. Lower voltage QRSs are normal. And an increased heart rate is normal with shorter R to R intervals. Normal signs and symptoms. Decreased systemic vascular resistance due to vasodilation. Again, these are all part of your normal symptoms of a stress test. Increased respiratory rate, sweating, fatigue, muscle cramping, increased blood pressure, and J-point depression. So this is your J-point. Remember your fish hook? Well, now we're going to look at what's called your J-point depression. So we know that we have our PR segment right here, and we have our ST segment right here. Because before this, we're going to have our P wave. Here is our Q, R, and S. And then here is our T wave. How do we know if we have ST elevation or depression? We're going to look at our PR segment. Our ST segment should be on the same line as my PR segment. If it is above, I have elevation. If it is below, I have depression. So here we can obviously see that my ST segment is depressed. J joint depression. So now that we know how to do the test, why we do the test, and when to stop the test, and when to continue the test, now how do we read our test results? So for example, for our Bruce, we're testing that patient, we're recording their heart rate for a total of 21 minutes, right? How do we read a rhythm that's 21 minutes long? Okay, so abnormal test is going to be indicated by the ST segment depression that doesn't return to baseline within 0.08 seconds after a J point. And there are three types. You need to know these. The three types are called upsloping, horizontal, and downsloping. The downsloping depression is the most indicative of CAD. Again, what is CAD? Coronary artery disease. So, remember your ST segment, right? So, over here is my P wave, and this is my PR segment, right? This is Q, R, and S. And then here we have my T wave. How can I tell if my ST segment right here is elevated or depressed? We're going to look at my PR segment, right? And we notice what happens on my S. I am going which way? Up. But am I at the level of the PR segment? No. So I am going upslope. Horizontal sloping is meaning here's my PR segment here. My ST segment should be here, but it is depressed, right? But it is just going kind of straight across. Whereas here we saw the ST segment going up. Here my ST segment is what? Horizontal. And then over here is your down sloping. So again, here is my PR segment. And here is my ST segment. Is my ST segment going horizontal? No. Is my ST segment going up? No. What is it doing? Going down. Down sloping. Alright, so here's a pre-existing resting EKG. So remember, before we do a stress test, we're going to take their rhythm at rest. And then here's your stress test. A positive stress test is going to be abnormal test indicated by a U wave inversion or a new appearance of U waves. It is indicative of coronary ischemia. Remember, that's your 3 I's: ischemia, injury, and infarction. That's the first level. Can we save the patient if they're ischemic? Yes. Injury, can we save them? Yes, but they will have damage. And infarction, can we save the heart tissue? No, it will be dead. The ST segment elevation is going to be an indication of transmural myocardial ischemia progressing to injury phase. The stress test should be stopped immediately to prevent permanent tissue damage. So what is indicative of an abnormal test, which would mean a positive stress test? You will see a U wave inverted or an appearance of a U wave, and your ST segment will be elevated, meaning we're heading into injury. All right, here goes your inverted U, so you can see here is my P, here's my Q, R, S, T, and then what's this right here? U. See it right here? U. And it's inverted, so it kind of looks like what? A, U. So, what's the reliability of the stress test? So, can we put all of our trust in a machine and what that machine's telling us? Our machine could be telling us our patients having a tachycardia, but they obviously are breathing normal and doing okay, right? They can be having a sinus arrest, but they're walking on the treadmill. So do we want to believe our EKG machine all the time? No. So we have what's called reliability of the stress test. The stress test is not infallible, meaning it can give us a false positive and a false negative. The gold standard, this is a test question, a national test question. It's on your quiz and it's on your homework. The gold standard of diagnosing CAD, coronary artery disease, is an angiogram. And we have what's called sensitivity and specificity. Sensitivity is the percentage of patients with positive stress test and a CAD proven by an angiogram. Specificity is the percentage of patients with a negative test and normal coronary arteries proven by angiogram. The term positive refers to the test's sensitivity. Negative is specificity. So you have to, this whole slide you really need to know by heart because they can ask you a ton of questions from here. What's the golden standard? That is diagnosing CAD with an angiogram. What is the sensitivity? That's the positive, and specificity is the negative, right? The percentage of patients with a positive test proven by angiogram is positive, sensitive. But the percentage of patients with a negative stress test proven by angiogram is the negative, specific. So these positive and negatives can be very confusing. So you need to memorize this by heart as well. It can be, if you think about it, it's pretty simple, but if you don't, it can be confusing. So we have 4 categories of a stress test. So we're looking at the results of a stress test. Was it positive or was it negative? How do we tell it's positive or negative? By the golden standard of proven by an angiogram. So what's a true positive stress test? That's when the stress test shows coronary artery disease, and so does the angiogram. So the stress test was a true positive. What is a false positive? When the stress test says that they have coronary artery disease and it's positive, but the angiogram says no, this patient does not have coronary artery disease. It is negative. So this would be a false positive. Then you have true negative, meaning the stress test says it was negative and the angiogram says there is no coronary artery disease. A false negative is when the test is negative, but the angiogram is positive. So this is just using that thinking cap, using your critical thinking. And we have different categories of stress test. So we have what's called Bayes' theorem. Bayes' theorem suggests that the true predictive value of any test lies not just in the accuracy of the test itself, but also in the patient's probability of disease as determined prior to the test. So for example, we're not just going to rely on that test, but we're going to look at the patient's history or their symptoms while they're getting the test done. The probability that they have coronary artery disease. So if somebody has chest pain, right? Then the probability of them having chest pain, of having coronary artery disease is high because they have what? Chest pain. Do risk assessment prior to the stress test to determine the likelihood that the patient has CAD, and then do the stress test. This is Bayes' theorem. After the stress test, if the stress test is positive, the patient will likely be either treated with medications or scheduled for an angiogram for further diagnostic evaluation. If the test is negative, there may be no treatment indicated. One of the first 5 strips assess the EKG and decide if the test should continue to be terminated. Assume this EKG was done 3 minutes into Bruce protocol. So remember, Bruce protocol is the maximum test, right? We're going to increase their elevation and their speed every 3 minutes for 21 minutes. And one of the signs of coronary artery disease is going to be the U waves, as well as ST elevation and depression. So you're just going to do a quick look at this strip, and you're going to see if you see any of those signs. And you're going to do that for all of these. Okay. So on the next 5 strips, you're going to assess the EKG and determine if the stress test is positive or negative for coronary artery disease. Then state whether the stress test is a true positive, a false positive, true negative, or false negative based on the indicated angiogram results. So you're just going to go through these and you're going to look. And again, what are we looking for? ST elevation, depression. Okay. So moving on. We just talked about stress test, right? We have different forms. A lot of information there, right? You have Bruce, modified Bruce, Naughton. You have heart rate at 85%, post-MI is at 70%. You subtract the patient's age from the 220. You have true positive, false positive, true negatives, and false. Lots of information there. This is all. You have a resting stress test, and then you have your exercise stress test, as well as a hyperventilating stress test. So now we're going to talk about Holter monitoring. And these are basically, this gives the patient the freedom to move about. So if you do a resting EKG, your patient's going to be lying down or in a seated position. They're not really able to move at all, but other than relax and breathe. But for my stress test, they're connected to the machine. They're doing exercise, so they really don't have too much movement. They can't take the electrodes with them as they get off the machine, right? And go down the hall to the restroom. So we have what's called our Holter monitors. And one type is our ambulatory EKG device. And I always think ambulatory, my first thought is what? The ambulance, right? But really, when you hear ambulatory, you need to think of movement, right? You're able to move freely. You're not stuck to a ventilator, right? So, ambulatory EKG device. It is used to rule out intermittent arrhythmias. Again, arrhythmias is abnormal. Or cardiac ischemia, which that's the first sign of a heart attack, right? The 3 I's, ischemia, injury, and infarction. That might be missed on a routine EKG. It can consist of electrodes and a small battery-powered digital flash memory device. It records the rhythm's data, data that can later be analyzed by computer, and the device is carried in a pocket or on a strap over the shoulder. It is done both on inpatient and outpatient settings. So ambulatory EKG, it is used to rule out arrhythmias that might have been missed on a routine EKG. It is battery powered by a digital flash memory device. It can be carried in the pocket or over the shoulder, both inpatient and outpatient. So what are some indications for a Holter monitor use? So again, are we just going to put a Holter monitor on anybody? Somebody healthy, no family history, and they want to come get a Holter monitor? No, we have to have symptomatic, right? So normally the indications to use a Holter monitor is somebody who is syncope, meaning they pass out, or they have near syncopal episodes, meaning almost every day they experience the possibility of going into passing out. Intermittent chest pain or shortness of breath, suspicion of an arrhythmia, and determination of arrhythmia treatment effectiveness. So again, Holter monitors are ambulatory, and this could be for patients who have had routine EKGs, who have the symptoms, but the EKG does not show that they're having these symptoms. So we might send them home with one of these monitors and monitor them over 24 hours. Preparation techniques. So you have to know these. These are very important. The majority of your national certification is going to be questions about these. And not just Holter monitors, but stress testing, medication. These last few chapters are crucial, and it's the majority of your test questions for the national certification. So the patient is attached to 5 or more electrodes on the trunk. When we talk about the trunk, we're talking about the torso, right? The trunk of the body, to prevent muscle artifact. The patient is given instructions, and you have to know these by memorization. Are the patients allowed to remove their electrodes? No. Can they take a bath or a shower? No. You want to get them electrocuted? No. They can have a sponge bath. Can they continue normal activities? Yes. Should they keep a diary? Yes. And mark the time, the symptoms, by pressing the marker button on the device. So basically, when that patient feels like they're syncope and they're about to pass out, what do they need to do? Press the button. What happens is it records their rhythm at that moment, so that when they go back to the doctor, they can say, I felt faint at this moment, and then the doctor can see if the heart is actually affected by it or not. So again, it could be 5 or more electrodes. This is what it looks like. It can be carried on, or it can be placed in the pocket. I want you to notice the color as well. On your online practice site, I'm pretty sure they're going to be going over these colors. You need to know what leads are for what color. You would usually learn this in class, in clinical, when we would do it on each other. I'll definitely see about getting a printout or something for you if it's not in your study modules. But again, a Holter monitor is ambulatory, movement, and it can be 5 or more electrodes. So once we have a Holter monitor, what is the positive? What is a positive Holter? So just like our stress test, we're going to have what? A true positive or a false positive, right? So our positive Holter is going to reveal abnormalities that could occur, that could explain the patient's symptoms. And notice this time they said abnormalities instead of saying arrhythmias. It might include a tachycardia, bradycardia, pauses, ST segment elevation, or depression. A negative Holter has no significant arrhythmias or ST changes. So even though my patient says she felt faint twice yesterday and she pressed the button on the Holter monitor, her heart is showing normal. So therefore it was a negative Holter, meaning there was no arrhythmias. And then we have what's called event monitoring. And this is for patients whose symptoms who are sporadic. So a small device, it is a very small device that the patient carries. It can be programmed to record abnormalities in the rhythm or ST segments, and can be activated by the patient whenever symptoms appear. There are 2 kinds of event monitoring. arrhythmia or ST segment activated, monitors your rhythm continuously, or a patient activated when the symptoms occur. So this is pretty self-explanatory to remember the differences between the two. You have two kind of event monitors, one which is arrhythmia or ST segment activated, meaning it monitors the rhythm continuously, or it is patient activated when the symptoms occur. So it can be carried or worn, just like our Holter monitor, and is useful in detecting rhythms of ST segment changes that even a Holter monitor might miss. And it is negative if the arrhythmia or ST changes are not found. So you could have a positive or negative event monitoring. This is Mr. Cameron's resting EKG. Right, looks pretty normal. This is his event monitor when he loses consciousness. In other words, he's passed out, right? Does not look normal. I see a bit of a sawtooth going on, right? And also a fibrillation.